Hey everybody, it is 12, so we are going to go on and get started with today's PD 201 webinar. This is the last one in the three part series, and today we are going to cover speech and some physical therapy. So we have Brittany McAndrew from our Cressman Center and Cressman Rehab, and she is a speech language pathologist. And then we will have for the second half Morgan Robertson joining us, and she is a physical therapist. So I'm going to turn it over to Brittany to get started. As the same with all the other webinars that we've had, if you think of a question during the presentation, you can go on and type that in the chat or the Q&A section. It'll pop up and I'll see it. Or then at the end, I'll remind you again, if any questions have come up, you can type it in there. We'll read them off and get those answered for you at the end. So at this time, I'm going to turn it over to Brittany.
Thank you, and thank you everybody for joining us today. We are going to be going over the rehab section as this part of the series, so intentional living with Parkinson's and holistic rehabilitation. And I wanted to give a little bit of an overview of what the rehab process is typically with Parkinson's for anybody that's has not experienced it yet. But the rehab process is a multidisciplinary team approach. So that is typically physical therapy, occupational therapy, and speech language pathology or speech therapy, same terms. And we start that rehab process from as day one of diagnosis at any point throughout Parkinson's, can even be if it started in more advanced symptoms. So rehab can be started at any point. We tailor wherever we are in the rehab process to whatever symptoms we're experiencing to meet the needs of what you're needing for your daily life. So how getting a rehab team is important, just as important as getting your neurologist and your medical team. You'll want to find, if you haven't already, a team of physical therapy, occupational speech therapy. Go in for your initial evaluations, and then you follow up every 4 to 6 months with that team to see if we need to adjust any techniques, any strategies, any treatment plans throughout. So earlier checkups if symptoms are changing more, longer checkup breaks if symptoms are slower. So each of the therapies between PT, OT, and SLP, we are with Parkinson's looking at walking, balance, strength, mobility. This is a lot of our physical therapy work that Morgan will talk about here in a little bit. Specifically assessing risk for falls and giving strategies to prevent falls. Also looking at fine motor changes. A lot of times our occupational therapists will look into this one a lot. Can be fine motor skills for daily living tasks, for getting dressed, for eating, navigating, writing. And then with speech, looking a lot at voice and speech changes, swallowing, memory changes. And memory, this one is also addressed with occupational therapy as well. But overall, we are looking at maximizing independence with daily living and finding strategies and tools to optimize this, working with family and caregivers to help support the process as well. So from a speech standpoint, I am, as far as motor symptoms of Parkinson's goes, I'm looking a lot at speech and swallowing. So the term dysarthria is a term that describes changes in speech. And this is probably the number one area that people see a speech therapist for with Parkinson's, because about 90% of people with Parkinson's will experience some change in speech. Could be different severities and it can progress at different rates with Parkinson's, but at some point in the Parkinson's journey, speech and voice changes in the majority of patients. And then swallowing, this could be disruption in any part of the swallowing process, from difficulty with pills to difficulty with foods and liquids, or even managing saliva, difficulty with drooling. And then we'll talk a little bit about that as well. So this one is a little bit more variable, can be 50% up to 80% of patients with Parkinson's experience changes in swallowing. So speech therapy is here to help navigate those changes and help preserve these skills as well. So we're going to talk about swallowing first. And I wanted to give a little bit of an overview of the background of how Parkinson's impacts speech and swallowing, because a lot of people are mainly looking at the physical motor symptoms like the tremor and walking, and this area is not discussed as much. But you have the part of the brain, the basal ganglia, that is responsible for automatic motor movements. And speech and swallowing are highly automatic. If you think about the process of stating a sentence, your brain knows what you're going to say. It talks to your lungs to tell your lungs how much air to get in for however many words your brain is getting ready to say. So if it's have a great day, that's a shorter sentence. My brain tells my lungs to take shorter breath. And then our lungs produce the breath. It talks to the mouth of how to produce the sounds. A lot of those things happen automatically. Same for swallowing. When we take a bite of food or a drink of water, a lot of that is an automatic process. So Parkinson's, we don't have as much dopamine. So those automatic functions are disrupted. And what that looks like is some changes with coordination between all the parts and some changes with reduced size or amplitude of the motor movements involved with that. So with speaking, if we have reduced amplitude or size of muscle movements with speaking, mouth movements can get smaller, and that can increase rate of speech and looks more like mumbling, what people perceive as mumbling. Or with swallowing, if our throat muscles aren't squeezing as food down as strong, food can get stuck easier. Or if our mouth movements aren't chewing as big and thoroughly, food doesn't get chewed up as much, and then we swallow more whole pieces that get stuck easier. So when those automatic movements don't happen as much, it changes the production with speech and swallowing. So with therapy, we retrain you how to use a different system of your brain to speak and to swallow, more of a cognitive or cortical control of speech and swallowing, which is called the pyramidal system. So one of the barriers that Parkinson's also affects is our sensory system. So whenever you're speaking or swallowing, it is very difficult with Parkinson's because of the sensory impact to know how muscle movements are being produced. So when voice gets lower, because Parkinson's impacts the sensory system, it's harder for you to detect that your voice is coming out lower. So when other people tell you, I can't hear you, or your voice seems lower than usual, it's hard to know. It's hard. You feel like you're speaking normal because of that sensory impact. A lot of people feel like other people's hearing is changing. So we also address that in therapy as this changes in the sensory system. So with swallowing changes, some of the more frequent complaints that people have with Parkinson's about swallowing is more difficulty chewing if it feels stiff or rigid with chewing muscles, or it could be difficulty clearing, getting stuck in the throat, whether that's food or pills. Can be increased coughing or even little throat clearing during meals. We specifically look, is it happening more during meals than outside of meals? Can look like a wet sound to your voice, more of a gurgling sound, constantly needing to clear something out. And it could be even lower, more of the GI tract, slowed transit through the esophagus or food pipe after it's been swallowed. Or it could just be unexplained weight loss, and we don't really know what part of the swallow system is being impacted, contributing to it. So I want to talk a little bit about drooling first. Drooling with Parkinson's is caused by saliva or spit that collects in our mouth. And it's collecting because our brain is not signaling as frequent of those automatic swallows. So when we're not swallowing as frequently, that saliva pools up. Again, that's a very automatic process. We typically, without Parkinson's, we do not think about swallowing saliva. So if it pools in the mouth, it's either going to come out the front if we don't initiate a swallow, or it can go back into the throat and make you cough if you're not ready for it. So one way to help with managing this, we can do some behavioral technique if it's not too bothersome. You just notice it a little bit. We can add things that help to trigger a swallow. So taking frequent sips of water. If you feel a little bit of it starting to come out your mouth, take a sip of water and that can help trigger a swallow. Or even sugar-free candy or gum can help trigger swallows. Ice chips. Other things, if it's more interfering with communication or even in sleep, when you can't really take a drink of water throughout all of your sleep time, your neurologist can also do some medical management. So that might be Botox to the salivary glands to reduce how much saliva you're producing, or it could be there's drops also to help reduce the amount of saliva. So that would be something to talk to about with the neurologist about more of the medical treatments. So from a speech pathology standpoint, whenever we see patients who have Parkinson's, who are complaining of some swallowing difficulty, or if other people are noticing it, we first assess the swallow. And that can either be done in the office and we watch you eat and drink and just watch how's your muscles reacting. Are we noticing any signs that it's going down the wrong way? Or we can do a swallow study where you sit next to an x-ray while you eat and drink, and we can actually look to see what the muscles are doing, if food's getting stuck anywhere, or if it's going down the wrong way. So we can actually see inside there. Or there's something called a FEES, fiber optic evaluation of swallowing, where we can actually put a camera inside and look inside your throat whenever you're swallowing. So from the swallow study that we do, we can give some different tips based on what we see to use at mealtime. But since we are changing the swallowing process from automatic to purposeful, changing our environment to allow you to be more focused during meals is key. So turning off the TV, keeping conversations to a minimum. Even visual clutter can sometimes be distracting, and you might see something, start reading it and forget, oh yeah, I got to think about this part of the swallow process. So even reducing visual clutter on the table can be helpful. Or if there's tips that you've been given to follow whenever you're eating and drinking to help it go down easier, having a list of that or those reminder cards on the table can be helpful. We do recruit any family or caregivers into treatment sessions to also help, because it is very hard to take something that is so automatic and give you 5 things to think about whenever you're eating and drinking. So if we can have support people also to help give those reminders. If it's getting very difficult to control the pace of your eating and start eating too fast, there's some strategies of, if simple as set your fork down in between every bite to allow yourself to chew and swallow, or even moving the plate to the side whenever eating and drinking. This one's sometimes more the one that we give to the family or support system there with you. Move it aside so that it forces you to really think about the swallowing. Or even simple as take a drink between every bite, forces you to put that fork down, take a drink, reset, and then move on. As far as some issues with if not eating enough, a lot of times let's look at appetite, talking with your doctor about any kind of medical management with that. We do also have nutritionists that can also give some support on the types of food that we're eating. Nutritional supplements give you the most bang for your buck calorie wise. As far as family support goes, we really talk about don't push food, don't make it an unenjoyable experience. Offer offer enjoyable food items without pushing it. Even if it's, let's eat a couple bites, take a break, and then eat later. So it might be more frequent but smaller meals. Now, the whole swallowing process being cognitive. We're being intentional about swallowing. So when you take a drink, feel the drink on your tongue, then swallow with purpose. Same thing when you eat. Feel the food moving from side to side. Feel it on your tongue. Now swallow with purpose. Make it a good strong swallow. If chewing is getting too difficult, reduce the demand for chewing. Cut it up really, really fine. Put more moisture with it. If it's way too much work, sometimes people will even put it in a blender and puree the food so you can just get it in. So it's just, we're giving the body fuel and moving on with our day. So thinking about some strategies like that to reduce the demand for chewing. Using a drink in between bites can help to wash food down so that it's not going to get stuck. So the next part that I was going to talk about is changes in speech and voice with Parkinson's. So we talked about the term for this is dysarthria, if you hear that term. And speaking with the motor movements, we talked about if the breathing muscles are not activating as big because of not enough dopamine, we don't get as much air in when we take a breath right before a sentence. If you don't take as much air in, we're not pushing as much air out, and so our voice isn't as strong. So voice can get softer. With it getting softer, our muscles aren't activating as much to give inflection, so speech can get more monotone. Maybe the voice sounds strong at the beginning of a sentence, but our brain didn't tell ourselves to take another breath, so then we keep talking at the end of the breath and voice can trail off. So those are some of the voice symptoms. Another part of what we look at with speech is the mouth. So how big our mouth movements are working when we talk to enunciate clearly and with control. Again, that's one that's dependent on dopamine. So speech can become less precise. It can be perceived as mumbled. It can then become faster, because movements are being reached earlier because they're not moving as big. So when we come in for a speech eval, we first look how's speech doing? If we really give your speech some stress testing, how's it working? Anywhere from it's working great, there's no detectable dysarthria or speech changes, all the way up till the end if speech is rare. We can work with any of these and we can help to optimize wherever we're at. So whenever we come in for an evaluation, once we determine where speech is at, we can talk about what kind of environment do we need whenever we're talking. Does it need to be one-on-one? Does it need to be turning the TV off and reducing background noise? Strategies to improve how intelligible speech is. Do we need to bring in different supplements? Sometimes pointing to things or gesturing can help give additional input to whoever you're talking to of what's coming out when you're speaking. We call that an AAC. So it's augmentative alternative communication, when we're starting to use different like picture boards, speech boards, things like that we can help set up. As far as therapy goes, whenever we do in-person therapy in our clinic, we're doing a lot of intentional voice and speech work. So there's programs we do a speak out therapy at Cressman, but there's also Lee Silverman voice therapy, if any of you have heard of that one. And so there we are working to improve muscle strength and activation. We're working on helping to preserve that. And then we're also helping to guide your home exercise program that you're doing, which should be happening every single day with Parkinson's to preserve that. So we do about a month or two of therapy. And then once we get your good home program down, then you do that once a day. And then we check in again every 6 or 12 months to see how we need to modify things. We also have therapy groups that we do on Zoom to help during that maintenance period in between in-person therapy. And then again, training with family or support people on communication strategies that can help as well. So some of these strategies are if we need to turn off the TV so there's not so much background noise. Again, speaking more one-on-one can be helpful. Definitely getting face-to-face, which is sometimes forgotten in a house environment when we're watching TV and look in one direction and somebody else is in the kitchen and we start talking. But talking about some strategies to get more face-to-face communication, making it very intentional. We'll talk about some tips to be understood. And we figure this out when you do therapy. Maybe it's training you to speak like you're speaking across the room, no matter how close the person is to you. Maybe it's thinking about speaking very purposeful or deliberate, using gestures and pointing to supplement what we're saying. And there's even things you can use throughout the house, like if it's hard to get voice out from room to room, like bells, call buttons, alarms. We can record messages on a phone. If you need to make a phone call, you can play a recording. So some things like that we can help set up in therapy. So if there are any caregivers or support people joining, or this could be things that you could help to communicate, sometimes because of the sensory impact with Parkinson's, it's helpful to get reminders to speak out. So prompting at the end of a question, tell me with intent, or speak out when you tell me. So this could be, what do you want for breakfast? Speak out when you tell me. So little reminders at the end of the question so that we can avoid something coming back in that can't be heard, and then we have to do it 2 or 3 times. Giving more time to speak. Sometimes we'll talk about some of the cognitive changes that can happen with Parkinson's can be slower thought process, so giving more time to communicate. And if you've got Parkinson's and need that more time, give a little nonverbal signal. I've got it, but give me just a second. So communicating what you need between each other. And then for caregivers, family, or support people, not pretending that you've understood, but telling them, I'm not getting it. I'm sorry. Let's try it again. Let's try it a different way. So being honest. And then lastly, from my end, the cognitive symptoms with Parkinson's. So cognition can vary with Parkinson's from normal cognition, normal age-related changes, little bits of forgetfulness, difficulty with names, that feeling that we've all had of, why did I just walk into the kitchen? Could be a little bit more due to the Parkinson's, which is what is called a mild cognitive impairment, which could be changes with executive function, which means our planning and organization, being able to take a broad task and break it down. Could be more in communication, so language organization, word retrieval, and then memory. And then if cognition is more impacted, then it is sometimes from your neurologist, this will be discussed in more of a dementia range, that it's progressing a little bit quicker. So speech therapy and occupational therapy both can address cognitive skills in any of those areas. So if attention is impacted, what that looks like is increased distractibility, more difficulty focusing on what people are saying, on what you're reading, on things that you're working on. Might be attention's pretty good at the beginning of the day, and then you really get wiped out at the end of the day. It could be that you're communicating and you lose your train of thought. That can also be due to attention. And then executive function we talked about is our higher level ability to plan and organize things. So thought processes can be a little bit slower through that, more difficulty sequencing or following multiple steps, and then with memory being a little bit more forgetful. So the role of therapy with these is we come in, meet you, we do our assessments, we provide education on where things are at right now, talk about strategies that can help, things, organization strategies that we can set up around the home, and then making sure that we have a good routine for brain exercise at home. There's a lot of research that shows that isolation is the #1 thing that contributes to worsening cognition wherever it's at, in the normal range to dementia range. So making sure that we have a good routine with physical activity, with social interaction, with cognitive stimulation. So we would help set that up in therapy as well. So supports that we can help provide, strategies for organization, ideas for staying mentally active, physically active, thinking about socialization and laughter, all of those good chemicals that our brain receives with that. And then, of course, adequate sleep. These are the things that we all feel no matter what. Getting adequate sleep can affect cognition, mood and mental health management. You all had heard from Tammy Evanow on this a couple of weeks ago, if you all were here for that series. And then staying on top of medical management, communicating symptoms with your neurologist and other doctors that you're seeing. And so these are some of the organization strategies that we set up to help with memory and executive function. And a lot of this can come from support people. But things like medication, pill boxes, keeping that simple. Let's reduce some cognitive load, put your pills in a pill box, set an alarm when it's time to go to them. You make sure you've taken them and we can move on. And even little reminders to go to it. Using calendars, or maybe it's even just a whiteboard with, here's what the date is, here's some things on the agenda today, some things to keep you organized. Using labels is huge. That can reduce a lot of cognitive load for time that we spend looking for things and planning things. So even labeling things like where the forks and plates goes if you want to be independent with unloading the dishwasher. It could be even to-do lists in the bathroom. Here's my sequence, what I do first thing whenever I wake up. And then we determine, is that better in picture form or is that better in word form? So that's some things that we can also help to navigate. So that is the end of what I wanted to go over from a speech standpoint. So we talked about changes with speech and voice and what we can do to help manage that, changes with swallowing, and then some cognitive changes. So Morgan Robertson is a physical therapist here at Cressman Rehab. She's going to be talking with you about some physical therapy management techniques.
Hello, everyone. I'm Morgan Robertson. I'm a physical therapist here at Cressman Rehab. And so what we're going to talk about today is kind of just thinking about like a holistic approach to physical therapy as Parkinson's disease progresses, changes, as we kind of move past some of those earlier stages. So when I think about physical therapy, as the disease progresses, I start thinking about how we can consider just like global health and wellness across all of the systems. So thinking less like about, super specific exercises or like super specific muscle groups, but thinking about like the whole person, the whole body. So things like respiratory control, cardiovascular endurance, and health, falls reduction, things that we might not think about like skin integrity, and then even mental health and how that relates to the physical activity aspect of the disease. This is a very wordy slide. I apologize, but I couldn't figure out how to condense it any better. But when we think about how this disease progresses, it's important to think about like kind of physically what's changing. So oftentimes, some of the symptoms will progress from one side of the body to both sides of the body. So thinking about things like rigidity, bradykinesia, which just is that fancy word for slowness, and then things like balance and even tremor, kind of taking over more of the body as opposed to just affecting like certain areas or more specific parts of the body. And then we start thinking about things like fluctuations related to our medication. So maybe early on in the disease, we can think about having more stability in symptoms throughout the day. And so as the disease progresses, oftentimes people get more on and off times, and that impacts their movement and their ability to exercise or, participate in activity. And then kind of as, Brittany was touching on, there are changes that happen with cognition, and that will make exercise and movement and physical participation more challenging for people, and it also makes it less safe for people, puts you more at risk for falls and things like that. And then, of course, there's some emotional and behavioral changes that progress as the disease progresses as well. So things like depression, anxiety, and apathy make it much harder to move and make it so that people might feel less motivated to get out and exercise or participate in their community or in their family activities. So I just wanted to kind of start by talking about exercise versus physical activity or engagement. Earlier on in the disease, we might be thinking more about very specific exercises to combat various symptoms of the disease. But as the disease progresses, I find it's more important to think about kind of global physical activity, engagement in our family and communities, and then just kind of participation versus doing these specific exercises every day. And I think in doing that, it can make it less overwhelming or less cumbersome for somebody who's having a harder time moving. And so the way we talk about this in physical therapy is just kind of trying to utilize everyday activities and turning them into ways that we can practice and get movement in our bodies without it being, super exercise focused. And the goals for PT at this point are to try to optimize your movement pattern. So that just means that, we're trying to make certain movement patterns you do during the day more efficient and easier for you. So that might be things like coming from sitting to standing, getting out of bed, walking throughout the home or out in the community. Even things that you enjoy doing, like, emptying the dishwasher. Not that we enjoy emptying the dishwasher, but it might be a chore that's important to you. Emptying the dishwasher or gardening. How do we do those things optimally so that we can participate, but we're remaining safe, and then we're not putting ourselves at risk for injury and things like that. So at this stage, we're going to focus less on exercise per se and focus more on maximizing moments throughout the day where we can work on specific movement patterns. And that's something we learn about in therapy. How do we optimally perform this task? And you can kind of work closely with your therapist and let them know what things are important to you, what things you want to keep independent. And they can help you certainly figure out how you can do that, and make sure that it's safe and effective and efficient for everybody involved. So focusing more on physical activity and community engagement is important because it allows us to prevent the risk for any secondary complications that I talked about a little bit earlier. So things like skin breakdown, swelling in the legs, joint pain and stiffness, changes in posture, and then of course the respiratory. So when we think about just something as simple as getting up throughout the day regularly, and so this is something I talk to people about often. So like making sure you're getting up at least every 2 hours for 5 minutes. So, and that's super simple. It's not, shouldn't be hopefully too overwhelming or cumbersome, but that's going to do a ton for you in terms of preventing any skin breakdown or pressure sores. And it's also going to help with the swelling in the legs, as well as joint pain and stiffness and all the others. But it's super simple. And, sometimes I'll have people set a timer every 2 hours. Make sure you're getting up, you're taking a stroll around the house, you're going to go get a snack, you're going to go use the restroom and maybe do a couple other things. And then, you can return to whatever you were doing before. But I do find a lot of people just end up sitting or laying down all day, and that's going to put significant risk on your body in different areas. That's going to put you at risk for skin breakdown, pressure sores, and things of that nature. I do find that the more we stop moving, the easier it becomes to stop moving. And so just taking those kind of small steps and starting to move more is going to lead to more movement, more ability, more independence. And so it seems really simple, but something like that can have a big, big impact on your health, your mood, and then your participation. All of these different things can have a major impact on our overall health. So I talked about skin breakdown or pressure sores, but also things like pneumonia and then hospitalization because of, different various health concerns related to our respiratory or cardiovascular health. And we know that Parkinson's does not in itself put us at risk for, Parkinson's itself isn't going to cause death, but we know pneumonia, falls, and all these other things are the real culprits. And so making sure we're moving regularly is gonna offset those quite a bit and allow us to be much healthier and reduce our risk for falling, and hospitalization as well. So what do we focus on in PT at this stage? We've talked about it a little bit, but specifically what can PT do for you? So the PT is going to help guide you on what things you should focus on. And the key with this is that it's going to be tailored to you as a patient. So, if Joe over here needs to work on his sit to stands and his walking, well, that might not be what Sandy needs to work on. She might need to work on getting in and out of bed or getting on and off the ground or something like that. And so the PT is going to tailor that guidance to specific activities based on what your goals and your specific symptoms are. And they're going to help you optimize the movement patterns. And so that's kind of the big word I like to use here is that, some of these movement patterns might not be perfect, or they might not be, we're not going to do 15 of them for exercise, but they're going to help you find the optimal pattern for you and your body and where you're at in the disease to make that movement easier for you. The PT should help you organize and prioritize exercises or activities that you need to be working on at any given time. And that could change day to day, week to week, and throughout, the disease process. The PT in this stage of the disease, the PT is going to have a significant role in supporting and training any caregivers or support partners in your life. So oftentimes I find that family doesn't really know like how to help somebody off the floor or how to help somebody out of the chair or help them get in and out of bed. And so the PT is a really good resource for you all in terms of getting people around you comfortable with helping you and optimizing your movement as well as preventing injury in themselves. Another really big focus of PT in these later stages is making sure they're talking to your neurologist about the changes that you're having, things that are adapting and changing, and so they can help coordinate any changes to medications or any other adjustments that you might need in terms of your medical treatment. At least here at this clinic, we have the ability to really communicate closely with a lot of the neurologists, and that might be on Parkinson's medicines, that might be in regards to sleep medications or psychological meds that aren't working well, and just being able to communicate your needs to your healthcare team is super important. And I think your PT gets to see you multiple times a week and give your medical team that feedback. And so I think that's a really big key as well. So later on in the disease, we might be leaning more on our support system for helping us with different tasks, with mobility or cognitive changes and things like that. And so I tend to emphasize more in these later stages the integration of our care partners. And so they're going to be more heavily involved with our PT sessions during this time. So we might need to be focusing more on training our partners and other support people who are going to be helping us, and then helping them get involved and get the care they need in terms of support groups and things like that, so that we're reducing their risk for burning out as a caregiver. So PTs might help a caregiver or support person give cues to a patient, the appropriate cues, and physically assist patients with transfers, walking activities, getting in and out of bed, and things of that nature. We really want to make sure that we avoid, our care partners getting injured themselves, because, for many people, we might have a spouse or a partner that lives with us, and their health and wellness is, very important as well. So we want to keep them healthy. And then we might be discussing as a group what kind of assistive devices could be beneficial to the patient and to the caregivers and support people. So that's something that we would discuss and kind of work through and figure out together. So when we're thinking about assistive devices or adaptive equipment, later down the line in the disease, we might be thinking about these things more as movement gets more challenging. The key with working with the physical therapist is that they're going to figure out what walker works best for you as an individual, as opposed to like, trying to go on the internet and find something out there on your own that may or may not work for you the best. And so the PT can help guide you and your care partners on what type of walker or other assistive device would be the most beneficial at that given stage in mobility level. Other things to consider later down the line are things like lift chairs, hospital beds, stair lifts, removable bedside rails, just as a little extra support for getting in and out of bed, wheelchairs, scooters. Those are all things I get questions about a lot, and it is not one size fits all for sure. And so that's again where you get that individualized approach from your physical therapist to figure out, is this something you need right now? Is this something we could wait on? Is this going to help your care partner improve their ability to get you out and about? So all of these things could be considered later on in the disease, but it depends on when and what you're ready for, and that discussion would be done with your PT and all your medical team and your care partners. Later down the line in the disease, we might be dealing with more kind of like medical issues. And so when I say medical issues, I just mean more things you kind of have to medically manage. And that might be via medication, that may be via other medical interventions, such as deep brain stimulation or different devices or different types of medications. And so things we're thinking about later on are things like freezing, where your feet are getting stuck to the floor, and that can be difficult to manage. Orthostatic hypotension, and so that's just when your blood pressure drops when you stand up, and that can put you at a significant risk for falling and passing out. And so that's something we want to monitor closely and get guidance on what types of things we should be doing to help combat some of that, and working with your medical providers as well to see if there's anything medically that can be done. Then thinking about other changes like dyskinesias and dystonias, oftentimes those are associated with on and off times. Thinking about how we manage those. Is it something like Botox? Is it a medication change? And your PT can certainly help kind of monitor those things and discuss those things with your neurologist. And then the other big one is falls. So reducing falls, making sure that we're staying as safe as possible so that falls are happening as few as absolutely possible. Because of course falls are going to put you more at risk for injuries and hospitalizations and things like that. So that's a big one as we move further on in the disease. So oftentimes I work with patients and care partners on falls. When they happen, what do we do? I think oftentimes people don't really know what to do or how to react when somebody falls, and so that could be a big focus in therapy on what do we do when somebody falls. So I did a quick little slide here about the overriding principles of what I would usually discuss with somebody regarding a fall. So making sure that we're sitting for a couple minutes, kind of assessing the situation, examining for any type of injury, thinking about if the person's on blood thinners or not, and if they've hit their head, then that's something that we would want to address quickly by going to the hospital to get a head scan. And then making sure the care partner feels comfortable getting the person up. And that could be something that a PT helps to train the patient and the care partner on, what kind of verbal cues to use and physical assistance, and what other devices could we use to help, like gait belts, a chair, a Hoyer lift, things like that. If you're unable to perform this transfer safely, we'll usually have you call the local fire department as opposed to 911 or something like that. So that's a nice alternative, and they're oftentimes ready to come and help people get up off the floor and kind of assess any needs for more medical treatment. So when we think about physical therapy in the later stages of Parkinson's disease, we think about the entire person, and not even the entire person, but their entire kind of care team. And so it's less focused on specific exercises for particular muscle groups or particular symptoms, and it's more of a whole person experience. And so we're thinking about kind of global health and wellness, activity versus exercise, thinking about emotional management, so breathing and movement, making sure we're advocating for ourselves and the things we need, so that you can participate in your community. Because as Brittany said before, that's going to put you more at risk for cognitive decline. And of course, it'll affect your mood and your desire to get out and participate. So we're going to focus more on our support system, the education and training on their end of things, and then monitoring for any medical issues, and making sure we're managing these appropriately, and communicating with your health team about any additional services or interventions that you might need. Here at this clinic, we take a very multidisciplinary approach, and so you might be seeing your neurologist, your PT, speech, occupational therapy, behavioral intervention. And as a team, we can kind of give you all the things that you need as things change and progress and adapt. Okay, so now I have completed my portion of today's talk. And so we wanted to make sure that we gave everyone time to answer questions or ask questions, and we will try to answer questions.
Yes, if anyone has any questions, we'll give you a few minutes here to, you can type them in the chat box or the Q&A box, and we will wait and see if anything pops up. Looks like somebody may have done the raise hand icon. Since
Here.
this is a webinar, we'll need you to type your question into the chat if that's possible.
Carolyn, we see your hand.
Yeah. If you can type it in one of the boxes, we can read it off. I'll do a chat and then maybe you can answer back to it. And also, if you do think of any questions after the webinar, you're always welcome to email me, and I can get the questions to our therapist and get some answers. And also, we can send out the PowerPoint too, if that helps people to go through it again, look at it, at your own pace. Okay, hang on, I think something's in the Q&A. Okay, good. Carolyn got it typed in. What causes freezing and what can we do when it happens?
So freezing, the like specific cause, I'm not quite sure. It's related to like the bradykinesia and that that kind of motor block that happens when we stop or try to turn. The main thing with freezing that I think is the opposite of what you would suspect is that when you feel yourself freezing, the first thing to do is to stop. And so a lot of people try to kind of push through their freezing when it starts happening, and that's going to tend to make it worse. And so what I always tell my patients is when you feel that kind of stutter stepping happening, you need to stop and kind of find good posture to reset, and then you go and take that step again. And I think the hardest thing about that is the attention to when that's happening, to kind of force yourself to stop and reset and then take another step. And so that just requires a lot of, mental attention and being really mindful of how you're moving around. But that's kind of the first step in managing those freezing episodes.
Okay, thank you. I don't see any other questions that have popped up. So we're probably just going to go on and end the webinar right now. But like I said, if you think of anything else, definitely feel free to email me here at the Resource Center. We can get, oh, hang on. We got another question. I spoke too soon. What can be done once a Parkinson's patient can no longer walk?
Um, I assume that means in regards to exercise, and so I'll answer it that way. But if it's something different, you just let me know. So if an individual can't walk, there are tons of exercises that we can work on sitting. So things like posture. There's a drumming class through the Norton Resource Center that you can do sitting, and you get great exercise in kind of your upper body and trunk that way. But there are a lot of options kind of for upper body weights, posture, amplitude training, and that's just kind of that big, fast movement that we work on in therapy, that you can do sitting down or you can do on a TheraBall or, different things like that. Even laying down and working on flexibility exercises, are wonderful as well. So there's a lot of options outside of just walking, that you can participate in, sitting and laying down. That would be super beneficial, and you could achieve a lot of your exercise goals that way.
Okay, we have another question. What about transferring when no longer walking?
So there's a lot of options for transferring without being able to see you or know you well. There are a lot of options for performing transfers if you can't bear weight on your legs. So a lot of times we'll use things like sliding boards here, and that kind of allows you to scoot across from surface to surface. That's one option. Or training, a care partner to be able to transfer somebody from surface to surface via different techniques where you use your upper body more. Those are just some, thoughts off the top of my head, but there are options certainly out there if you can't bear weight on your legs. And outside of even just kind of physically using your body to transfer, there are things like Hoyer lifts that will allow patients to transfer from surface to surface with the use of a lift. So there's some options available, for sure, for people who can't bear weight on their legs. And that would be something you would work with your PT on, is kind of like what's going to work best for me. Do I need a device or do I not? And just kind of see what works the best.
Okay, I don't see any other questions. One might pop up though, like it did last time. But I think at this time we probably will end the webinar. We did record this, so we'll be sending out information when all of our PD 201 videos are ready to be viewed. You can always go through them again. And like I said, we will send out the slides so you can look through those at your own pace. And thank you, Brittany and Morgan, for joining us today.
Thank
And
you.
everybody else, have a great afternoon, and we'll see you at our next sessions. Thanks.
Thank you.
Bye-bye.
Yeah.
Bye-bye.